Good evening, respected seniors and our dear students. It is an honor and privilege to invite our Honorary Secretary, ISA National, Dr. Bajwa sir, to please welcome everyone.
Thank you, Dr. Parul. It's my pleasure to welcome all the people, especially the seniors, the juniors, everyone, because everybody now log on to these classes. They participate in a very fruitful discussion, ask very good questions also, and take this topic to a much higher level, which is mentioned in the books. Because these topics, whatever being discussed on these platforms, apart from the bookish things, apart from the theoretical things, many times we get a feedback, we get a whatever you call the experiences of the learned people, which give us more insight into how to deal with those complications or situations. As you know, anesthesia is just another branch of medicine which is highly evolving. So many times, whatever the ideas we get from these classes, from these situations, from the people, they add further to our knowledge, our skills, our practice, and new perspectives to those clinical situations. Today, we have got a eminent faculty from Kolkata, and I think I will be very lucky to have Dr. Parul, Dr. Madhuri, Dr. Nishant on the board to introduce them. And the honors will go to Dr. Parul to introduce the class. Dr. Madhuri, Dr. Nishant will also be taking over with Dr. Parul to take with the questions and answers, and we will be enjoying the session today. Dr. Parul, you start the class and you please introduce the faculty.
Thank you so much, sir. Before we start the session, let's invoke the blessings of Ma Saraswati.
सरस्वती नमस्तुभ्यं वरदे कामरूपिणी विद्यारम्भं करिष्यामि सिद्धिर्भवतु मे सदा.
Once again, a very good evening to all of you. We all know that infants and young children are not small adults. One size fits all does not apply in pediatric age group. No one can be an airway wizard because airway management in pediatric patient is scary. There are no magical equipments, gadgets, and secrets to easy pediatric airway. The training for pediatric airway is an ongoing process. We are really grateful to Bajwa sir today that he thought of this topic, and we'll be having an interesting discussion on this. May I request sir to kindly introduce the topic?
You do the honors, don't worry, Parul, you carry on.
Thank you so much, sir. So, may I start my screen sharing? So today's PG online class is a short case discussion on anesthesia for foreign body bronchus in a child and anesthesia for microlaryngeal or laser surgery in a child with local cord pathology. Some of the guidelines for this session is that please mute yourself while the lecture is going on. We are live on YouTube at the rate ISA NHQ. The question asked by the teacher to the audience can be written in the chat box. You can post your questions in the chat box, which will be taken by the faculty at the end of the sessions. And all the lectures are available at the ISA website. It is our honor to have our Dr. Mausmi Niyogi, Professor and Head, Calcutta National Medical College. Her area of interest is neurosurgery, plastic surgery, and pediatric surgery. Her achievements is MD in anesthesiology and 15 publications in national and international papers. We welcome you, ma'am. Please take the chair. Our second moderator for today is Sudeshna Bhatt. She is an associate professor in Department of Anesthesiology, Calcutta National Medical College. She is a life member of ISA, IPA, IDA, and IMA. Her area of interest is pediatric anesthesia and regional anesthesia. Her achievements are she is an AHA certified BLS and ACLS provider. She is instructor in PPLS and completed the RBCW. She has been a speaker in many state, zonal, and national conferences and participated in many workshops as faculty. She has more than 22 publications in national and international journals, and she's an EC member in IPA Bengal. She has received the late Dr. T.N. Jha Memorial and Dr. K.P. Chaurasia Medal for Best Paper Presentation. To support her, we have Dr. Swapandeep Sen Gupta, who is an assistant professor in Department of Anesthesiology and Critical Care, Calcutta National Medical College. His major achievements are that he's a life member of ISA, he's a regular speaker at different ISA conferences, several publications at various international and national journals. I welcome all the chairpersons and the moderators for the session. The PG students today are Dr. Salona and Dr. Kaushik Chatterjee. May I request Dr. Mosmi ma'am to kindly start the session?
Thank you, Dr. Parvati, for your kind introduction. I would like to thank ISA National and our Honorary Secretary, Dr. Badva and Madhuri ma'am, for giving us this opportunity. Today, we will discuss two short cases. Speaker of the first case is Dr. Salona and moderator is Dr. Swapnadeep Sengupta. Dr. Salona, please start your presentation.
Thank you so much, ma'am. Good evening, everyone. I will be presenting a case today on anesthesia for foreign body bronchus in a child. Avinash Kumar, a 3-year-old male child resident of Topsia, Kolkata, West Bengal, came to the ER department with presenting complaints of cough for 5 hours, which was sudden in onset, difficulty in breathing while running or jumping for 2 hours. The history is reliable as the informant being the mother. History of present illness. Patient was apparently fit 5 hours back when he accidentally aspirated on a peanut while munching on them and developed choking followed by vehement coughing. The coughing subsided after some time with the child being restless and complained of something stuck in the chest. Cough was sudden in onset, dry in nature with no productive sputum. On and off coughing was present. There were no aggravating or relieving factors. Patient had his meal 5 hours back. The child also complained of difficulty in breathing while running or jumping for 2 hours. It was not associated with any pain, nasal flaring, severe dyspnea, or chest retractions. There was no history of fever, sore throat, hoarseness in breathing, bluish discoloration, noisy breathing, or difficulty in breathing while feeding. There was no history of any drug or food allergies in the past. History of past illness. There was no history of choking in the past, no history of any breath-holding spells, asthma, or tuberculosis, no history of any hospitalizations in the past. The child had a normal developmental history with an institutional normal vaginal delivery, cried immediately at birth, with all vaccinations complete till date. There was no history of any congenital anomaly and all milestones were achieved as per age. Patient was having normal bowel and bladder habit with normal sleep-wake cycle. On general examination, patient was irritable and crying inconsolably. The patient was afebrile with vital signs of pulse rate 120 beats per minute, which was regular in rhythm, fair in volume. With all peripheral pulses felt, there was no radioradial or radiofemoral delay. Respiratory rate of 35 per minute. While on auscultation, bilateral vesicular-bronchial sounds were present. However, air entry was decreased on the right side as compared to the left, and wheeze was also present on the right side. Patient had no signs of pallor, cyanosis, icterus, clubbing, or any edema. There was no engorgement of veins or any other neck swelling present. On respiratory examination, patient was found to be tachypneic with no signs of gross deformities, chest retractions, paroxysmal breathing. Chest appeared to be normal in shape with trachea central and not deviated. Respiratory movements with thoraco-abdominal with not associated with nasal flaring. On auscultation, Patient had bilateral vesicular-bronchial sound present with decreased air entry in the right side. Wheeze was also present on expiration on the right side. All other systemic examinations were within normal limit. A quick airway examination had face appeared to be normal with no anomaly noted. Mouth opening was adequate. However, Malanpati scoring could not be elicited due to the child being irritable. Hence, this is a case of foreign body in the airway causing partial obstruction.
Thank you, Dr. Salman, for that nice presentation. Well, managing a pediatric airway can always be challenging. And a patient like this, a pediatric patient with a foreign body in the airway, can be even more challenging for obvious reasons. Now, we will gradually discuss why this is even more challenging, why I am saying that it is even more challenging, but we will start with the basics. Okay,
Yes,
so Saloma, can you tell me the incidence rates of these kind of cases?
So the incidence rate of these kind of cases being 4.3 per 1 lakh. Generally, they have a male preponderance.
Okay, and what is the commonest age group of patients who are complain of these kind of features?
So commonest age group in these kind of cases is ranging from 6 months to 4 years. Most common being 1 to 3 years of age.
Okay, so late infancy and early childhood, right? That is
Yes.
the most common age. So can you elaborate why these children are more vulnerable for getting a foreign body asphyxiated in their airway?
So children are more of this age group are more vulnerable to foreign body aspiration because of the following reasons. First of all, children have this natural urge of putting everything in their mouth and exploring everything that they get in their mouth. Secondly, they have an immature glottic reflex and poor coordination between the mouth and the tongue. They have a lack of molar teeth for chewing nuts or any other food particles. Also, the patient have they constantly cry while eating and playing, and lack of parental supervision.
Okay, so exploring the world through their mouth and an underdeveloped or immature glottic reflex. These are the most important reasons, factors that why this age group is more vulnerable, right? Now, what are the common types of foreign bodies that can be asphyxiated?
So foreign bodies that are aspirated can be broadly classified into organic and inorganic. Under organic, we have the following list. For example, seeds such as watermelon seeds, peanuts, as in the case that I have presented, grapes, bones, popcorn kernels, etc. Under inorganic, we have the following list: screws, nails, pins, safety pins, needles, coins, and also batteries.
Okay, so it's broadly classified into foreign body types into organic and inorganic. And obviously, your patient has taken a peanut, so it is an organic foreign body. So why are we just dividing this broad classification, making this broad classification? Is there any implication if the foreign body aspirated is an organic one?
Yes, sir. If we see for the organic foreign bodies, they tend to swell up with time. They absorb water and swell up with time, causing a partial obstruction into a complete one. And also, they tend to release some substance secretions, oil secretion, as for the case of peanuts, causing edema and inflammation in the tracheal mucosa, thus obliterating the lumen. Also, with time, they become friable and the fragments can be dislodged into smaller airways, thus failure for removal of foreign bodies. And in the long way, they can cause strictures, granulations, thus causing further complications.
Yes, gradually with time, an incomplete obstruction can convert into a complete obstruction, which becomes a dire emergency. And removal takes more time because they can be fragmented while taking it out. Okay, but if it is not an organic, say it's a needle, as you were mentioning, or an open safety pin, pointed sharp object, what will be the problems with that?
So sharp and pointed objects are associated with a high rate of morbidity and mortality, as these can cause erosion, ulceration, and most of the time perforation, thus leading to further complications such as strictures and fistulas.
Yes, trauma to the airways, the most important thing that we fear of. So they should also be taken out very safely and very early as possible, in fact. Okay. Now you also mentioned about batteries when you were mentioning the inorganic lists. So what kind of batteries can be asphyxiated and what are the implications if a battery is aspirated?
So lithium-based batteries, button batteries, are most commonly ingested by the pediatric cases, and the reason being these are small, shiny objects which are tend to easily engulfed by the children. But the problem with these batteries are that within a few hours, these batteries can cause electrolysis reaction in the airway, and which will cause in a few hours of time cause coagulative and liquefactive necrosis, thus causing organ perforation mainly in the trachea and other airway where they are lodged, and thus leading to complications such as granulations, strictures, and further complicating the case.
Exactly. For these cases, obviously, if they're aspirated into the airway, they should be taken out very early, even if they are going into the esophagus. Okay, so batteries should be removed as early as possible. Now, these are about the types of foreign bodies. Now, once aspirated, where do the foreign bodies generally lodge?
So common sites of impaction are trachea, the larynx, bronchus, mainly in the right bronchus, and smaller airways.
Okay, so you said mainly in the right bronchus, right?
Yes.
Why the right bronchus is more vulnerable?
So the right bronchus is larger in diameter, thus allowing more airflow. The airflow is greater. Also, the angle of divergence with that of the trachea is more in line with the trachea. That is, angle of divergence is smaller and it is more in line with the trachea, causing an easy impaction of the foreign body. Also, the carina is left to the midline. Hence, right bronchus is more vulnerable to foreign body impaction, sir.
Okay, very good. But you mentioned first larynx and trachea. So if a foreign body is lodged into the larynx or the trachea, it will cause a complete obstruction, right?
Yes.
Which is absolute emergency or dire emergency. So what could be the clinical features if you can find a patient with a complete obstruction in the airway?
So, if a patient presents with complete obstruction, the presenting symptoms will be the patient will be in choking, gasping. Also, there will be vehement coughing. If there is a complete obstruction for a longer period of time, patient can also present with hoarseness, aphonia. There will be severe dyspnea. There can be progressive cyanosis, asphyxia, which might lead to impending cardiac arrest.
Exactly. So complete obstructions, a patient with a complete obstruction may not even reach up to the emergency, may even succumb before that if the level of the severity is such. Okay. So this patient which you are getting, you are lucky enough to get an incomplete obstructed case, right? So what could be the clinical features other than what you have found in this patient? What could be the other clinical features in a patient with an incomplete obstruction where the food particle or whatever asphyxiated has gone down, maybe into the bronchus or something like that?
Yes. So in case of an incomplete obstruction, patient will initially present with coughing and choking. Then an asymptomatic phase will be followed where the presenting symptoms will subside or reduce, which will be followed by a complication phase in case of a long-standing undiagnosed or diagnosed cases where the fragments may further dislodge into the airway. So a complication phase will be followed, which will present where the patient will present with abscess, atelectasis, pneumonia, pneumonitis, etc.
Okay. So incomplete obstruction mostly occurs when the foreign body gets lodged into one of the two bronchi, mainly the right bronchus, which is more common as you have said. So can you tell me the classical triad if we are getting a patient with foreign body in the bronchus? What is the classical triad of features?
Yes, sir. The classical triad in case of a foreign body bronchus or partial obstruction, which includes the following. First, the patient will present with paroxysmal coughing. There will be unilateral decreased or diminished sound, airway sounds. Also, patient will be presented with unilateral wheeze.
Okay, fine. So now regarding the pathophysiology, we are getting an array of symptoms and signs in patients with obstructive and complete and incomplete obstruction cases. So regarding the pathophysiology, there are several valve mechanisms which actually give rise to these kind of different symptoms. So can you give a light or elaborate a little bit about those valve mechanisms?
Yes, sir. There are three types of valve mechanism in case of a foreign body aspiration in the airway. First being the two-way valve mechanism or the bypass mechanism, where the foreign body bronchus may let the ingress and egress of the air. That is, there will be air entry and there will be air entry and the air can move out of the lungs. But the second case, that is the one-way valve mechanism or the check valve mechanism, where only the air entry or the ingress of the air is seen, and this might lead to obstructive emphysema. Third valve mechanism is the no-way valve mechanism or the stop valve mechanism, where there will be no ingress or egress of the air. Thus, it will be leading to atelectasis.
Okay, very good. Now coming back to the practical aspect once again, once you get a patient like this, is there any scope of investigations that you can do?
So, since this is an emergency situation, scope of investigations will be depending on whether the patient has landed with a partial or complete obstruction and whether the vitals of the patient are stable. If the time permits and the patient is not in respiratory distress and the vitals are stable, then we can go for a quick chest X-ray under CPC.
Okay, but if you're getting a complete obstruction, you seldom get any time for any kind of investigation. You have to just rush into the OT so that you can take out the foreign body as soon as possible and open the airway for the child. Okay, but even if an incomplete obstruction, you're planning for a chest X-ray. Can chest X-ray gives any valuable information at this early stage?
So generally, chest X-rays are not so much feasible in case of foreign body bronchus at the earlier stages, that within 24 hours, as no proper test findings can be seen in the radiographic films, because 90% of the organic foreign bodies are radiolucent, and also the immediate chest findings such as mediastinal shift or atelectasis or hyperinflation of the contralateral side is not visible, sir, in the early phases.
Yes. So 90% of the foreign bodies are radiolucent. So in the early stage, if the child is brought early enough, then you will not find much features in the chest X-ray, right? But if it is an unwitnessed foreign body aspiration, the child presents after a few days, what could be the possible findings that you can get out of a chest X-ray?
Sir, if the child presents a long-standing undiagnosed case or the child presents after a few days, then we can find the mediastinal shift, ipsilateral atelectasis, contralateral hyperinflation, and if it is a lateral decubitus film, then there will be absence of mediastinal shift, sir.
Sir, may I interrupt for a moment? We have some queries from the audience. Whether we are sharing a screen, so let me tell you, we are just having a discussion right now. The slides, we are not sharing the screen. Salona is not sharing any screen right now.
Okay.
Dr. Salona, please share your screen.
Yes, ma'am.
Is that okay now, ma'am?
Sir, is there whatever we are discussing, is it on the screen also? Or we are just having a discussion?
No, actually, we are having just the discussion. The screen is showing.
That is what the audience wanted to know. Are we missing out on the
No, nothing.
Thank you so much, sir. Thank you so much. I'm so sorry to disturb.
No, it's so fine. Okay.
Thank you so
So
much.
can we continue now?
Please continue, sir. Please continue.
Okay, thank you. So getting back to the case, Dr. Salona?
Yes, sir.
Yes. So why are we so concerned with these kind of cases? What are the probable complications of a foreign body in the airway, especially in a pediatric patient?
Yes, sir. The complications are can be broadly classified into acute and chronic. Under acute, there are various complications that can be seen, such as rapid desaturation leading to hypoxia, causing hemodynamic instability, which might progress to cardiac arrest and hypoxic brain damage. There can be trauma to the airway, complete airway obstruction, dislodgement of the foreign body further into the airway, barotrauma, laryngospasm, and bronchospasm. However, under chronic complications, which are like undiagnosed foreign body or long-standing foreign body aspiration cases, there can be subglottic edema, atelectasis, pneumothorax, pneumonia, pneumonitis, and pneumomediastinum.
Okay, so pneumonia and pneumonitis are one of the more common features which the child presents with if he or she had a undiagnosed or unwitnessed foreign body aspiration. So, non-resolved pneumonia can be a case of, always we have to keep in mind that a non-resolving pneumonia can be a case of foreign body lodged somewhere in the lower bronchus or bronchi,
Yes.
right? So,
Yes.
when you're treating this patient, when you got this patient, what was your management of choice?
So management of choice in these cases will be removal of the foreign body via rigid bronchoscopy under general anesthesia.
Okay, so in this semi-emergent patient, you are going to give general anesthesia, right? So what could
Yes,
be
sir.
the anesthetic concerns in this case?
So anesthetic concerns in this case is because of the first reason being handling of the irritable child. Since the child is a pediatric age group, handling of the irritable child is first concern. Then, since this is an emergency case, the child can come with full stomach. Then there are difficulties pertaining to the pediatric airway. Then we have difficulty to maintain oxygenation and ventilation as the pulmonary gas exchange is already reduced. And lastly, we are sharing the airway with the surgeon.
Okay, so pediatric airway is always a concern for us, right? So can you specify reasons why a pediatric airway is always a concern, or how the pediatric airway is different from the adult airway?
Yes, sir. So concerns regarding pediatric airway are, first of all, the children, they have a large head with prominent occiput, and they have a relatively smaller mouth opening in relation to the large tongue. Also, the mandibular angle is around 140 degrees. They have a high arched palate and elongated floppy epiglottis, which is angled at a 45 degree with that of the tracheal axis. Also, they have higher anteriorly placed larynx at C3, C4, which is at an acute angle with the base of the tongue. Also, the cricoid area is the narrowest part.
Okay, now again coming back to the case, when you receive the patient in the emergency department, how will you proceed?
Yes, sir. So as soon as this child is received in the ER, a short history is to be taken with a thorough examination to look for bilateral breath sounds, signs of any partial or complete obstruction. Then a quick airway assessment can be done for laryngoscopy. If time permits, and the patient is stable, then a quick chest X-ray can be done. After that, when the anesthetic plan is being decided, a quick informed consent from the parents or legal guardian is to be taken before we proceed for the procedure.
Yes, an informed consent from both the parents, if available, or a legal guardian after explaining the situation and the probable outcome of the management. That is very important in their own understandable language. Is very important for before proceeding for these kind of cases, right? Other than taking
Yes,
this all those things, are there any specific other preoperative preparations that you will like to take before taking up this patient?
Yes, sir. After taking a informed consent from the legal guardians or the parents who are present, we can go for a proper antibiotic coverage, and aspiration prophylaxis can be done for the patient, and if at all, we can secure an IV cannula if the child allows with a proper IV fluid infusion. However, the NPO guidelines may not be strictly followed because this is an emergency situation, sir.
Yes, proper resuscitation, if the hemodynamic instability is there, has to be made. And NPO guidelines, as you have said, because it is an emergency, may not be strictly followed, right? But this is about the patient operation. How will you prepare the operation theater before proceeding with the case?
Yes, sir. Before proceeding with the case, and as this is an emergency situation, we have to make sure that all the machines in the OT are in proper functioning status. That is the anesthesia machine with the pediatric circuit, the suction machine with the appropriate size suction catheter, laryngoscope with appropriate size blades, all other drugs and equipments in an ambient OT temperature, sir. That is ranges between 20 to 24 degrees centigrade.
Okay, so I've prepared the OT. Now you said that you will give general anesthesia. What is the special type? What special type of anesthesia will you plan?
So,
What will
in this patient, yes, sir. In this patient, we will prefer general anesthesia with inhalational induction, that is with sevoflurane and oxygen in spontaneous ventilation, sir, through a ventilating bronchoscope.
Okay. Through the rigid ventilating bronchoscope, you will just maintain the oxygenation and the level of anesthesia with sevoflurane, right?
Yes, sir.
Okay. Is there any scope of pre-medication in
Yes,
this
sir.
patient?
Yes, sir. We can pre-medicate the patient with an anti-syllagogue agent, such as injection glycopyrrolate, 5 micrograms per kg body weight. However, we wouldn't prefer any kind of sedation because the airway is already compromised and there's always already reduced pulmonary gaseous exchange.
Okay. So after that, how will you induce the patient?
Sir, induction of the patient will be done with the inhalational agent such as sevoflurane with oxygen. And after deepening the plane of anesthesia, we will leave the plane to the surgeon for them to properly anesthetize the airway, either through atomization or through topical spray, that is 2% lignocaine spray, and they can further proceed with the removal of the foreign body, sir.
Okay, so maintaining the plane with sevoflurane, oxygen, and local anesthetics, right?
Yes,
That's
sir.
what you're planning. Are you planning to give any muscle relaxant to this patient?
No, sir, I would not prefer to give immediately a muscle relaxant because it may worsen the situation by converting a patient with an already compromised airway to a patient having no airway at all, sir.
Yes, plus when you are giving muscle relaxant, you need to give positive pressure ventilation, which may dislodge the foreign body further down. And that can create problems, even more problems for the surgeons to take it out, right?
Yes, sir.
Okay. So you are maintaining with oxygen and sevoflurane, as you have said. Are you going to add nitrous oxide to this patient?
Sir, I would not prefer nitrous oxide in this case because nitrous oxide gas is known to increase gas volume, air trapping, and thereby causing possible rupture of the affected obstructed lungs, sir.
Okay, other than sevoflurane, you are not adding nitrous oxide, you are not giving muscle relaxant. Other than sevoflurane, can you have any other alternative intravenous drug option to maintain the anesthesia during the procedure?
Yes, sir. We can maintain the deeper plane of anesthesia by adding an infusion of Dexmed infusion at the rate of 1 microgram per kg body weight, sir.
Yes, because until and unless you are removing the foreign body, the oxygenation or the ventilation may not be adequate because of that obstruction. So IV drug, if can be given, can be a better choice sometimes.
Yes, sir.
Right.
Dr.
Yes.
Sen Gupta, can we take a few questions by the audience at this point?
Yes,
Whatever we have discussed, we have a few questions from the audience.
Okay, okay, no problem.
Can Dr. Salona take these questions? So the first question
sure.
is, can she get, what are the differential diagnoses for paradoxical movement?
Yes, ma'am.
Salona, the question is, what is the differential diagnosis for paradoxical movement?
Yes, ma'am. Ma'am, a state of complete obstruction, complete
Right.
airway obstruction.
What else? It could be a chest wall tumor in childhood and adolescence also. It could be a trauma.
Yes, ma'am.
Actually,
Yes, ma'am.
actually, any obstruction of the upper airway can cause a paradoxical movement.
Paradoxical.
That, other than that, any chest trauma, as you were mentioning, that can injury to the ribs, fracture of the ribs, that can cause a paradoxical movement. Any compression of the chest wall by some tumors or SOL, these can cause a cause paradoxical movement. And also if there is a localized weakness of the muscles of the chest,
Yes.
that can also cause localized movement, paradoxical movements.
Okay. So the next question is sharing the airway with the surgeon good, or is sedating the patient and allowing the surgeon without a definite airway a good or a bad option?
Ma'am, can you please repeat the question?
Dr. Raghuvan, is sharing the airway with the surgeon good, or is sedating the patient and allowing the surgeon without a definite airway a good or a bad option?
Ma'am, sharing of the airway with the surgeon is good. Instead of having no airway at all, because otherwise, like we can lose the patient. Already there is a reduced pulmonary gaseous exchange because of the partial obstruction, and if we lose the airway, then it would be worse in the case.
Okay.
Actually, the thing is that when we are removing the foreign body, this pediatric airway is already a narrow airway. So if we put our own endotracheal tube, the surgeon will not get enough space to take out the foreign body, right? So we have to leave the airway to them so that they can negotiate the bronchoscope. And because we are nowadays having ventilating bronchoscopes, we can easily ventilate with that also. So we were coming to that question also. So
Yes,
that a better choice.
Okay, so what is the role of analgesics and management if there is a complete obstruction?
Role of analgesics and ma'am?
First, let's take this question. What is the role of analgesics? Can you mention any analgesic here?
Analgesia, we can use fentanyl, ma'am. We can use fentanyl. We can use Yes, ma'am.
So is there any role of dexketamine, combination of dexmedetomidine and ketamine for this patient? Can you use this combination?
Ma'am, dexmed can be used. Ketamine can also be used, ma'am.
The combination of both can be given.
Yes.
So let's go ahead with the discussion. Over to you, Dr. Sen
Okay.
Gupta.
Okay, thank you, ma'am. So after the monitoring, now what we were discussing, that we will allow the surgeon to put in the rigid bronchoscope, the ventilating bronchoscope, right? And we will ventilate that ventilating port. So Dr. Salona, can you tell me how we can check for the adequacy of oxygenation and ventilation once we are ventilating with that ventilating port of the rigid bronchoscope?
Yes, sir. Adequacy of ventilation can be checked by seeing the equal chest rise on the both sides, and also on auscultation, whether the bilateral auscultatory breath sounds are present or not. Even the surgeons can confirm the patency of the airway through the while the procedure, and we can also check for the saturation in the monitor, sir.
Okay, so after the foreign body has been removed, how will you proceed with the patient? What will you plan to do with after the foreign body has been removed? How will you proceed to for the management of the patient?
Yes, sir. After the removal of the foreign body, since the patient is always already in spontaneous ventilation, sir, we will mask oxygenate the patient. That is, and till the emergence. Mask oxygenation of the patient will be till emergence, sir.
Okay.
Mask
so
oxygenation.
Yes, so because you have not given any muscle relaxant, you have the scope of mask oxygenating the patient till emergence. But there is one thing that has to be taken care of, that after that handling of the airway, there could be edema. If there is severe edema which can again compromise the airway, we may have to intubate the patient, or if the patient has to be given muscle relaxant for some reason, then we have to again intubate the patient with a appropriate size tube till the patient is reversed, right?
Yes.
Fine?
Yes,
okay. Sir. So after that, now what is the role of is there any role of any steroids in these cases?
Yes, sir. In these cases, foreign body impaction might cause edema and inflammation in the mucosal airway or the tract. and hence use of steroids will help in reduction of these symptoms, that is the inflammation and the edema, thus improving the post-operative outcomes.
Yes, so anti-inflammatory effect of steroids can be very much utilized in these cases, right? What could be the possible intraoperative complications during the procedure that you have to be careful of?
So intraoperative complications will include rapid desaturation, leading to hypoxia and thus causing hemodynamic instability, and which will cause impending cardiac arrest and also hypoxic brain damage. There may be trauma to the airway or barotrauma, laryngospasm, bronchospasm, further dislodgement of the foreign body into the smaller airways, and there may be atelectasis or pneumothorax.
Okay. Now, if you are not getting a ventilating bronchoscope, what are the other possibilities or other options you have for maintaining anesthesia to this patient?
So other modalities that can be used are jet ventilation, apneic ventilation, and TRIVE, that is transnasal humidified rapid insufflation ventilatory exchange.
Yes, TRIVE is a novel technique which can be well utilized. High flow of oxygen at the rate of 20 liters per minute around for a pediatric patient can be given, and that really increases the apneic time and allows the surgeon to give more time to the surgeons to remove the foreign body. Okay.
Yes.
Now, if your patient had come with a complete obstruction, what would be your approach? How will you manage?
So if generally patients with complete obstruction rarely make it to the ER, and they might collapse even before reporting to the ER and might land in the cardiac arrest. So these kind of cases require immediate removal of the foreign bodies. And if the patient lands in the ER with a cardiac arrest, we have to do resuscitate the patient, giving CPR to the patient. So.
Okay, so if it is the obstruction seems to be high up and the patient is collapsing, you may also have to approach with an emergency cricothyrotomy or like that, if required, right? Not cricothyrotomy, maybe tracheostomy, emergency tracheostomy. If the case is severe and the foreign body seems to have lodged in the upper part of the airway. Okay, so what could be the post-op management of this patient?
So post-operatively, we have to meticulously monitor the patient, and in case of any airway obstruction or because of the edema or due to any trauma or injury caused during the procedure, there might be an airway edema which might cause obstruction. And might further need to intubate the patient. So meticulous monitoring for saturation, BP, and heart rate is to be done, and also patient to be properly given antibiotic coverage with steroids in order to improve the post-operative outcomes.
Okay, so now after this, can you tell me a few maneuvers if a foreign body aspiration is in the airway is witnessed out of the hospital immediately? Can we do some maneuvers so that we can save the patient?
Yes, there are different maneuvers which can be done out of the patient. If the patient is patient is being taken and out of the hospital. So there are different maneuvers such as finger swipe, and finger swipe to be done in an unconscious patient, and the foreign body is visualized by naked eye, and with a single stroke, it should be taken out. Other maneuvers will include Heimlich's maneuver and back slaps.
Okay, so this is a brief discussion about a very important case, a very challenging case for all the anesthesiologists, how to manage a foreign body in the airway in a pediatric patient. So,
Dr. Gupta, can we take some questions at this point?
Sure.
Related to this case?
We are almost at the end of the first session, so we can take questions, no problem.
Right. Quickly, we'll take some questions. The first question is, foreign body in bronchus after removal, is extubation immediately a good option or not?
Actually, it depends on the clinical status, the hemodynamic status of the patient, what kind of foreign body has been aspirated, where it was lodged, And is there any chance of high edema or chemical reaction with the mucosa and all these things? Considering all these things, we have to plan whether we can immediately extubate the patient or we have to go for an elective ventilation.
So the second question is, what will be a superior approach, an inhalational or an IV based, like propofol, remifentanil infusion with spontaneous ventilation?
Actually, spontaneous ventilation is ideally should be maintained. Okay, so if the obstruction seems to be partial and can be well ventilated, oxygenation and ventilation and inhalation agents can be well maintain the plane of anesthesia, then it can be a good choice. But if the obstruction is severe enough that the oxygenation or actually the inhalation agents cannot reach the lower airways, then obviously IV maintenance will be the only choice. But again, IV can cause apnea, high dose. If given in a high dose, it can cause apnea, which can again complicate the scenario. So if possible, inhalation is good. If not at all possible, then we have to go for IV.
Okay. So can succinylcholine and atropine infusion be used, and what is the dose? Hello?
Huh?
So the question is, can succinylcholine and atropine be used, and what is the dose?
If we are planning to maintain a spontaneous ventilation, then succinylcholine should not be used ideally. Plus, this is a 3-year-old child. So in a 3-year-old male child, succinylcholine has its own effects, risks. So succinylcholine, I don't think would be a very good choice, especially if we are going for a maintenance dose.
Okay. So there's another question, which is, if a foreign body is in GIT, especially an alkaline battery, what could be the management?
Well, if it is a battery, then as I have said, the battery has its own reactions, the chemical reactions that can injure the mucosa. So that has to be removed as early as possible. And
Right.
that even if it is in the esophagus or the GI tract, it needs to be removed as early as possible. But in that case, we have an advantage that the airway is free for us. So we can easily intubate after giving muscle relaxant, and then the battery can be taken out. We don't have an issue with sharing the airway in that case.
Okay. And suppose if the battery is or a chemical agent is in the bronchus, so our option will be to prolong the ventilation or immediately extubate him.
It again depends on how long the battery has been aspirated. Okay, if it is witnessed and has been immediately taken into the ER and the battery is taken out intact, we can find that the battery is intact. We can easily safely leave the patient after emergence. But if after taking it out, if the battery doesn't seems to be intact, then there are risks of chemical injury to the airway. So in that case, it's better to intubate the patient and ventilate till the recovery.
Thank you so much, sir. So can we proceed to the next scenario?
Shall I add certain
sir.
things here?
Please, sir.
Sure, sir. Sure, sir.
Yeah. First of all, regarding that first part, the extubation process, whether you want to proceed for extubation, that also depends upon how much trauma it has caused to the bronchus.
Yes, sir. That's why I was saying the trauma and edema.
Basically, the sharpness of the foreign body, the linear trauma or the circumferential trauma, and the duration of the foreign body in that particular bronchus, about the edema, because that cannot be clinically assessed, which can be assessed only under vision of the bronchoscope or the pediatric bronchoscope. I think to extubate, the decision should be because there's a dilemma here. Why either we are taking out that foreign body in an institutional setup or a peripheral setup, you don't get the access to foreign fiber optic bronchoscope everywhere.
Exactly.
So it's a very difficult decision to be made in the periphery. I think in such things the duration is long. If you think the prospective trauma must have happened here, I think it's better to delay extubation and do it in a very manner, in the ICU or wherever you can put the patient in the high dependency unit. So that is one thing. Regarding the alkalinization, I think even the same thing principle applies for the battery broken. Once the alkali has released in the bronchus, that means it has already got its cascade reactions. that cascade reaction does not subside immediately. It has a long-lasting effect for more than 24 to 48 hours. I think it's better to wait for any damage to the foreign body if the alkali is there. That has to be taken into account. Delay your extubation, don't worry. Third part was the infusion of scoline and atropine.
Atropine, sir.
I think it's obsolete nowadays. Why to proceed with these drugs when they have a cardiac effects? Already the airway is compromised, and Dr. Swapandi was very much right about the inhalation going to the particular bronchus and uptake and distribution mechanism of inhalation anesthetics. So it's better that if the child can be brought up on Tiva or something like that. I think those are the very simple thing. We can proceed with that. So these are very well answered, and very well, I think, taken care of by the dynamic faculty. So I think these were my just inputs, no suggestion, inputs.
Thank you, sir. Thank you so much. Thank you
Thank
so
you so much, sir. And we have Dr. Madhuri Kurti, ma'am. Ma'am, would you like to say something?
Yeah, what is the role of jet ventilation? Has she told? Saloma, she has told the role of jet
Yes, ma'am.
ventilation in
Ma'am,
such
she said
cases.
about that.
Okay, so everything depends upon how fast the surgeon is able to remove the foreign body. So the
Precisely.
more the duration, the more they struggle to remove the foreign body, more the airway edema which is going to occur, and then more the post-operative mortality and morbidity. And what are the most common complications that occur during foreign body bronchus removal, Dr. Saloma? Can we just
Yes, ma'am. Ma'am, complications, intraoperative complications, ma'am.
yeah, perioperative.
Perioperative, yes, ma'am. Ma'am, most common complications will be rapid desaturation, causing hypoxia, which can cause hemodynamic instability, leading to impending cardiac arrest and hypoxic brain damage. There can be laryngospasm, bronchospasm, airway trauma while during the procedure. It can also cause, ma'am, further dislodgement of the foreign body into smaller airways. The fragments maybe can also lead to atelectasis and might be in other worsening of the situation, pneumothorax.
Yes, and for how much of desaturation is allowed, like during those moments when the surgeon will be trying to remove the foreign body, and if you're doing it by apneic method, especially if you're doing it by apneic method.
Ma'am, desaturation up till 90% and for less than 1 minute, madam, not more than that. Like
But
1 minute of
sometimes we allow them to let the SPO to go up to 80, like that. In 90, I don't know, like whether you can elaborate on this, like how safe is it?
I will tell Dr. Madhuri, it's not that safe, you know, for a pediatric age group from 1 year to 10 years. Every infant, neonate, and pediatric patient has got a different residual, you know, volume. So whatever the hypoxia they bear, it depends upon their age, their development of the lung system, the pulmonary tissues, the hypoxia the brain can bear. It can vary anywhere from 1.5 minutes to 4 to 5 minutes. But that itself is not going to be, you know, our baseline, how to allow that much hypoxia for that particular minutes. Ideally, 1 or 2 minutes trial is a good enough for any foreign body to be taken out, which can be easily accessible. Taking more than that is definitely going to prolong the hypoxia, and the risk of brain damage is more than the risk posed by that foreign body, in particular bronchus. In such cases, it depends upon the child's age, how much the pre-oxygenation, how much 100% oxygenation, how much lungs are filled, so that we get ample time, so that we get ample hypoxic time or anoxic time to remove the foreign body. But ideally speaking, if it's not out in 2 to 3 minutes, what I feel, because after 3 minutes, even for the 2-year-old child, the brain's ATPs, they go. The reserve ATPs go. You will start having anoxic metabolism, you start having the catabolism, and you start having all the complication of hypoxia and anoxia. So I think 2 to 3 minutes is a good time, although there is no established study in a different age group from 1 to 10 years. If you go by the clinical situation, it's all depend upon the clinical situation at that particular moment. If the surgeon say I can bring it out in 2 minutes, 10 seconds, You don't stop that at 2 minutes. Okay, 2 minutes over, you take it things over. You also have to watch clinically. You have to see the every surgical step clinically at what stage they are, whether they will be able to retrieve it in 2 to 3 minutes maximum. I think that is my personal opinion, depending upon the experience gained over the years, one in the books, in the Miller, and all the other books also. That is the ideal thing to do, but there is no established time limit for such things.
That is why, because of the dangers of the apneic method, we have methods like jet ventilation and all nowadays, where the chances of hypoxia will be less.
Jet ventilation not easily available. It's not easily available everywhere. Rather than, I think, very simple method is the pre-oxygenation. Good pre-oxygenation for a 3 to 5 minutes is a good making up of the residual volume of the lungs.
Yes, and the expertise of the surgeon also matters a lot.
Yeah, definitely.
I think there's a very good question in the chat box, Parul. What if the foreign body slips?
Body slips. Ma'am, I was about to come to that.
Read that question. It's a very nice question.
Sure, ma'am. So the question here is, what happens if the foreign body slips in the trachea and there is sudden desaturation? How do you manage it?
If it slips in the trachea and causes a complete obstruction with sudden desaturation, a better option will be just push it down to one bronchus so that we can ventilate and get some time, so that the saturation improves. We can get some time and again try another attempt so that we can get some more time. We can buy some more time. That would be the best option.
Yes.
So may I request Dr. Surekha Chauhan?
Yeah, I've already allowed her to unmute herself. Ma'am Surekha, you kindly unmute yourself.
Yes, sir. Thank you, sir. Actually, I'll share some experience because of doing too many foreign body bronchoscopy in Sassoon Hospital, BG Medical College.
Yeah,
so
please proceed. Please proceed.
Regarding peanuts, I'll share that most of the times they can be chronic foreign body bronchus, and they are diagnosed pneumonia cases from pediatric department, and they come as a last resort to check the foreign body. So that one thing, such patients are quite critically ill, needs definitely to be evaluated, and again post-operative post foreign body ventilatory support has to be kept in mind. That is one aspect. Another thing, after removing the peanut, always everybody is in a stress, including surgeon and anesthetist. They want, they get relieved after seeing the peanut by foreign body bronch. But it is a very checking and not to be hurry. Anesthetist must make the ENT surgeon to recheck the bronchus again to know the any additional pieces of the that fragment of peanuts. Most of the time they are there, and then after they come out and they give the patient to us, and if we keep on managing, saturation doesn't improve. It happens. So check bronchoscopy after removal of peanut foreign body is must. We should not relax after seeing one piece of peanut. Definitely.
Thank you, ma'am. It's a definitely very good answer, and that to add to it.
One more. Before inducing any foreign body case, appropriate tracheostomy tube size for that age group is must to be arranged on a preparation trolley. Otherwise, it can create a big chaos, which we had one case where we had to cut a trachea directly because the foreign body is stuck up, and then there was no tracheostomy tube. So we had to put a Portex tube and somehow pinch that trachea with the artery forceps and somehow ventilate. That baby we saved and went walking home. That was about, you were saying a saturation, how much to drop. There was no saturation, there was no heart. It was blue black baby, and literally that was a critical moment when we had to cut the trachea, pull out that it was a seed, tamarind seed, swollen tamarind seed. And then we saved that baby by cutting the trachea. So these are many practical aspects. But surgeon totally depends on us whether to start or when to stop. That is totally in our hand.
Yeah, that's what I was saying. The swelling of the foreign body in the bronchus, which can pose further problems after swelling this one. These bodies can get broken up and they can further migrate to the smaller airway tissues, and I think that is the problem. I think, ma'am, airway set we always keep ready. The tracheostomy we kept ready, but sometimes the body is foreign. It's an intubation or tracheostomy is one and the same thing. They don't give much advantage. The tracheostomy doesn't give much advantage over the intubation process in these
Yeah,
things.
yeah.
So that's okay. So I think your experience is well taken. And
Yeah.
Parul, I think you should proceed forward.
Yes, sir.
Okay, thank you, sir.
Thank you so much, sir. So there have been few comments by Dr. Anita Kohli, ma'am. She says, can you give you can give oxygen with nasal cannula simultaneously to avoid desaturation. And there's another comment which says, even when you're taking out the foreign body, keep on looking into the oral cavity, as the foreign body may dislodge during the removal and may lead to again aspiration. So these are the two comments, and there is a query again. The query is that if it is an alkaline battery in the esophagus or it is in the bronchus, so what are the signs or what are the things you have to look out as toxicity during the intraoperative and postoperative period, and what are the basic things to look out after the foreign body removal and perioperative complications? Shall I repeat the question again?
Yes, sir.
Okay, so the first part of the question is whether the alkaline battery is in the bronchus or the GIT, what are the signs or things to look out for toxicity intraoperatively and postoperatively?
Yeah, intraoperatively, as I've already said, that these batteries they cause electrolysis reaction. Like within few hours after they are ingested, and then they cause coagulative necrosis and liquefactive necrosis, thus leading to perforation and edema, inflammation. So these can cause like due to the edema and inflammation, there will be compromised airway. So patient will present with first of all, due to the irritation, patient will be presenting with coughing. Then there would be patient will complain of tightness in the chest, restlessness. Patient can also complain of difficulty in breathing later, dyspnea, and if it is somewhere near the trachea or near the vocal cords, patient can be with severe dyspnea, aphonia, hoarseness, all these kinds. And later, the patient can also, if the airway is completely compromised, or there might be, then patient might present with progressive cyanosis and with athletics, so like further complicating the situation. Intraoperative, there can be rapid desaturation as well, causing to hypoxic, instability, hemodynamic instability, and hypoxic brain damage.
Good. Dr. Sen Gupta, do we have any more questions for the PG, or can we move on to the next scenario?
I think Parul, move to next part so that
Yes,
we
sir.
can have all the questions together at the end of the second
Right,
part.
sir. Thank you, sir. So may I now invite Dr. Kaushik Chatterjee to present the second case. Dr. Kaushik, kindly share your screen.
Thank you, ma'am.
Your slides are visible. Kindly take it to the slideshow and start your presentation.
Good evening, everyone. I am going to present a case on anesthesia for microlaryngeal surgery in a child with vocal cord pathology. Mohammad Irfan, a 4-year-old male child residing at Park Circus, Kolkata. He was admitted in ENT department on 3rd November 2023 with the chief complaint of progressive breathing difficulty for 1 month and hoarseness of voice for last 2 months. He was apparently normal 2 months back. Then he develops hoarseness of voice as stated by his mother. Then he develops progressive breathing difficulty, which was aggravated in lying down position and gets relief when he turns to one side. The child is irritable, though there is no feeding difficulty. No history of any fever, sore throat, running nose, cough, bluish discoloration of the body at present. He had a history of laryngeal papilloma excision under general anesthesia 7 months back, which was uneventful. No other significant past medical or surgical history present. He was a uneventful antenatal period followed by institutional normal vaginal delivery. His birth weight was 2.2 kilo, immediately cried after birth, and no congenital abnormality detected at the time of the birth. His immunization status was also complete. He attained all his developmental milestones according to his age. There is no allergic history to any drug or food present. His father is a rickshaw puller and mother works as a housemaid. He has 2 siblings, a 7-year-old brother, and 1 year of younger sister. His family belongs to poor socioeconomic status. The child is alert, conscious, but irritable. He was thin-built with poor nutrition, weighing 15 kilo with height of 97.5 centimeters. There is no evidence of any pallor, icterus, cyanosis, edema, or clubbing present. No neck vein are palpable, no neck vein are engorged. His pulse rate was 112 per minute, which was regular, normal in volume, palpable at all peripheral sites with no radioradial and radiofemoral delay. His respiratory rate was 30 per minute, which was thoracoabdominal in type. Blood pressure was measured at right arm in sitting position, which was 100 by 60 per millimeter of mercury. At the time of general survey, the surface temperature of the child was normal. On airway examination, nostrils are patent, mouth opening was adequate, Malampati gate could not be elicited, thyromental distance was normal, no loose tooth found, and neck movement of the child is adequate. On systemic examination of the respiratory system, no suprasternal or subcostal suction is present, trachea central in position, bilateral vesicular breath sound present, no other adventitious sound noted. The examination of the other systemic examination like cardiovascular system, GI system, and central nervous system within normal limit. On indirect laryngoscopy, grape-like papillomatous growth seen over vocal cord. So this is a case of recurrent respiratory papillomatosis in a 4-year-old male child posted for microlaryngeal surgery. Thank you, ma'am.
Thank you so much, Dr. Chatterjee. Can we have the questions from the chairpersons and the moderator?
Yes, ma'am. Thank you, ma'am. Good evening, everyone. Dr. Kaushik, so this is a 4-year-old child with features of airway obstruction. But the airway obstruction is not so severe that he needs immediate airway intervention. Now, can you tell me what are the differential diagnoses of a patient?
Madam, the differential diagnosis in this case grouped into congenital causes, neoplastic causes, neurological or infective pathologies, out of which the most common causes are recurrent respiratory papillomatosis, vocal cord nodule, subglottic stenosis, subglottic cyst, glottic wave, hematoma, or foreign body infection in the larynx.
Okay. Now, your patient had a past history of excision of laryngeal papilloma, and the indirect laryngoscopy, which was done by the ENT surgeon, has also revealed the presence of grapes-like papilloma in the area over the vocal cords. So your provisional diagnosis is recurrent respiratory papillomatosis. Now, can you tell me what are the causes of this disease?
This disease mainly caused by human papillomavirus type 6 and type 11.
Yes, good. Now, what are the common clinical presentation in such a patient and how severe can it be?
There are two varieties of the disease, juvenile onset and adult onset one. Juvenile onset is more common and it is affected the 2 to 4 years old child. Patient initially present with hoarseness of voice, and then depending on the severity of the airway obstruction, patient may develop breathing difficulty, weak cry, stridor, and aphonia. Suprasternal and subcostal suctioning may also be present in severe airway obstruction. Extensive laryngeal involvement may lead to chronic airway obstruction with the subsequent development of pulmonary hypertension and pulmonary features.
Okay, so airway obstruction is the predominant clinical feature in these patients. So can you tell me what are the common locations of these papillomas?
Recurrent respiratory papillomatosis can spread throughout the airway tract, but the larynx is the most commonest site of the infection.
Yes, good. Now, what are the common modalities of treatment in such a patient?
Yes, ma'am. Microlaryngeal debulking surgery is the mainstay of treatment. Among them, carbon dioxide laser and microdebridal excision of the lesion is the most commonly used. Besides that, there are certain adjuvant treatments such as acyclovir, intralesional cidofovir, subcutaneous interferon alpha injection. HPV vaccination has been found to reduce the severity of the disease and the frequency of the surgical intervention. Despite that treatment, the recurrence rate is quite high in this disease.
Yes, the recurrence is always very high in these patients, and many patients are posted for repeated surgery for the excision of laryngeal papilloma. Now, you please tell me what investigations will you ask for this patient?
Investigation in this patient will guided by the physical examination and the history of the patient. In this case, I will go for complete hemogram and chest X-ray PFU.
Okay. So this is a case of difficult airway in a pediatric patient, which is always very challenging to all of us. And there is always chance of perioperative, any sort of complications. So how will you counsel the parents or the legal guardians of this patient, and how will you take the consent?
I will be clearly explain the legal guardian of the patient with the known language of them, with the various anesthetic risks and the ventilation strategies for this patient, and with the need for emergency tracheostomy also. After explaining this, I will take the written consent, inform consent from the patient party.
Okay, so you have completed the investigations and you have also taken the consent from your patient. So now you are ready to provide anesthesia to this patient for microlaryngeal surgery. So first you tell me, what are your anesthetic goals?
Anesthetic consideration for the microlaryngeal surgery in this patient are mainly maintaining the good surgical exposure with immobile surgical field, adequate relaxation of the vocal cord, adequate oxygenation with the appropriate ventilation technique, maintenance of the cardiovascular stability of the child, avoidance of any airway trauma, which may lead to laryngospasm, and prevention of aspiration.
Okay, good. Now, this is obviously a case of difficult airway, and you have to keep ready the difficult airway card. Now, can you please enumerate what are the things that you will keep in the difficult airway card?
The difficult airway card in pediatric patient include pediatric face mask of different size of nasal and oropharyngeal airway, pediatric laryngoscope, pediatric laryngoscope, blade of alternative design and size, video laryngoscope, supraglottic array of different types and size, endotracheal tube of different size, suction apparatus with suction tube of appropriate size, and surgical airway card.
Okay, good. Now, you please tell me, how will you pre-medicate this patient?
During the preoperative visit, I will build a rapport with the child to allay his anxiety. As there is chance of airway obstruction in this case, I will not give any sedative pre-medication. I will only give the injection glycopyrrolate as an anti-sialogogue.
Okay. Now, what is your plan for induction of anesthesia?
As this is a case of anticipated difficult airway, I will try to maintain the spontaneous ventilation with sevoflurane and oxygen inhalation.
Okay. Will you use any neuromuscular blocking agent in this patient for endotracheal intubation?
No, ma'am. Neuromuscular blocking agent reduces the airway muscle tone. That can lead to complete airway obstruction, which make the intubation more difficult. I will not prefer the neuromuscular blocking drug in this case before intubation.
Okay. So as there is an obstruction at the level of vocal cord, it is better to maintain the spontaneous respiration till the airway is secured. But here I like to highlight one thing. When you are taking the history, the careful history taking and physical examination will give you a rough idea of the severity of airway obstruction. And moreover, the indirect laryngoscopy, which is usually done by the ENT surgeon, will tell you the condition of the vocal cords. That is, whether there is near complete obstruction or there is still some space through which you can negotiate the endotracheal tube. So here it is better to induce a child with inhalational anesthetics, maintaining spontaneous respiration. And here also usually the time of induction is relatively longer due to airway obstruction. But ultimately the child will be induced by inhalational anesthetic, and your main aim will be to maintain the spontaneous respiration. And if there is considerable amount of airway obstruction, then obviously you have no choice. There you cannot administer any neuromuscular blocking agent. There you have to intubate the child under deep inhalational anesthesia. And topical application of lignocaine will help you in these cases. But if the airway obstruction is not so severe and the direct laryngoscopic view shows that there is enough space to negotiate the endotracheal tube, then you have another option. That is, first you can check the ventilation, whether you can ventilate the child with bag mask. If you can ventilate, then you can administer the neuromuscular blocking agent and you intubate after adequate muscle relaxation. Because we all know that when we are intubating after adequate muscle relaxation, the technique becomes easier, and also there is less chance of airway trauma due to the patient movement. So, but I again repeat, if you have any doubt regarding the ventilation as well as regarding the intubation, then it's better not to lose the airway. You maintain the spontaneous respiration and intubate the child under deep inhalational anesthesia. Okay, very good. Now, can you elaborate what are the ventilation strategies that can be used in such a patient?
Ventilation techniques are used for microlaryngeal surgeries are positive pressure ventilation with tracheal intubation, spontaneous ventilation with TIVA or inhalational agent, apneic intermittent ventilation, and jet ventilation.
Okay, for this patient, which strategy will you prefer?
I will prefer the positive pressure ventilation with endotracheal intubation.
Okay, what are the advantages and disadvantages of this technique?
The advantages of this technique is mainly the adequate airway protection, control of the patient immobility, and vocal cord relaxation with the use of neuromuscular blocker agent, stable and controlled ventilation, and continuous monitoring of the FiO2, EtCO2, and anesthetic gases concentration.
And what are the disadvantages?
Main disadvantage are the sharing the airway with the surgeon. So surgical field may be inadequate for the lesion excision, and this type of ventilation also unsuitable for surgery of the posterior glottic pathway growth.
Yes, good. But as you have mentioned that there are some other ventilation strategies also, and someone has also asked in the chat box that whether any tubeless technique is there or not. So we will discuss a little bit of these techniques. The first one is spontaneous respiration. What is this? When there is anticipated difficult intubation and ventilation, you may continue with the spontaneous respiration. The child is usually induced by inhalational anesthetics using oxygen and sevoflurane, and you have to maintain the spontaneous respiration. So obviously there is no role of any neuromuscular blocking agent here. And you can apply the topical lignocaine over the vocal cords, and the surgeon proceeds with the surgery. Here the main advantage is that there is very good surgical exposure, as there is no obstruction by the endotracheal tube, and the surgeon can also evaluate the vocal cord function. But the disadvantages include difficulty to assess the ventilation, surgical field is not still, there is chance of aspiration, and the depth of anesthesia is also not very consistent. And obviously the pollution of the operating room is also a problem. Another technique is intermittent apnea technique. Here what we do, now following the induction of anesthesia, muscle relaxant is administered and positive pressure ventilation is continued. After adequate ventilation and oxygenation, the patient is handed over to the surgeon and he starts the surgery. But here we have to be very meticulous. We have to be very careful to monitor the oxygen saturation. Once the saturation decreases, as just in the previous case, Sir has already discussed it, once the saturation starts falling, we have to ask the surgeon to stop the surgery. And then the trachea is intubated and ventilated with 100% oxygen. And after this ventilation, the oxygenation is improved. Then again the ET tube is removed and the surgeon starts the surgery. But here the problem is that we have to have a very good rapport with the surgeon, and the surgeon should be very first, as the surgical time is very much limited. There is also chance of inadequate ventilation and aspiration. And there can also be airway trauma due to repeated intubation attempts. But the advantage is that the surgical exposure is excellent, as there is no endotracheal tube. And the operative field is still, and the vocal cords are also relaxed. But Sir has already mentioned this is a relatively risky procedure. So it is best suited for short, uncomplicated cases, and it is especially useful for laser surgery. Another technique which is also discussed in the previous case, that is a jet ventilation technique. The high frequency jet ventilation, it's a commonly used technique. What we do here, a high velocity jet of oxygen is directed above or below the glottis, and the lungs are ventilated with oxygen and the entrant room air. Here the venturi principal acts that we all know. Now, the anesthesia is maintained with intravenous agents and muscle relaxants. It provides an unobstructed and still surgical field. It is very widely used in adult patients, but in pediatric patients, it should be used cautiously because there is chance of barotrauma, air trapping, and pneumothorax. And obviously, we need a special device for this technique. Okay, so these are the common techniques, that the so-called tubeless techniques, which will prevent us to share the airway with the surgeons. Now, Dr. Kaushik, how will you monitor this patient in the intraoperative period?
Yes, ma'am. I will monitor the patient in the operating room with the ASA standard monitoring guideline with pulse oximetry, ECG tracing, non-invasive blood pressure monitoring, ETCO2 measurement, temperature recording with the access to the precordial stethoscope auscultation.
Yes. And will you extubate the child at the end of the surgery in the operating room?
I will extubate the child in the operating room, as after excision of the lesion, the airway obstruction is relieved.
Yes, very good. This is actually a case of obstructed airway in the preoperative period. But once the surgeon excises the papilloma over the vocal cord, the obstruction gets relieved. So it is an usual practice to extubate the child in the operating room. But as we are dealing with the airway, especially in a pediatric patient, there is always chance of complications like laryngospasm, bronchospasm, and many more. So we have to be very careful, and we have to detect if any complication arises, and we have to manage accordingly. Okay, now tell me, what are the common postoperative complications in such a patient?
Operative complications in these surgeries are airway edema, laryngospasm, bleeding and aspiration leading to hypoxia, written secretion, which may subsequently develop atelectasis.
Yes. So what extra precautions will you take in the PACU?
I will monitor the patient in the postoperative care unit with the standard monitoring guideline to detect any airway obstruction features, and keep the patient on moist oxygen inhalation, IV fluid, adequate analgesia, IV steroid like dexamethasone to reduce the airway edema. If airway edema is already developed, I will prefer nebulized epinephrine in this patient.
Okay. Now, I want to ask you a very interesting question. Here you have said that the obstruction lies at the level of vocal cord. So if you perform tracheostomy, it will bypass this obstruction. Now, will you prefer tracheostomy in your patient?
No, madam. Because the tracheostomy increase the risk of the viral spread to the distal airway. And as there is growing skeleton, and there is, after surgery, there are some anatomical deformity in the larynx may develop. So I will not prefer the tracheostomy. If tracheostomy done for severe airway obstruction, the emphasis should be on the early decannulation.
Yes, very good. Now, such type of surgery can also be done using the laser. This is a common technique. Now, what are the different types of lasers that are available, and what type of laser is most commonly used in laryngeal papilloma excision?
Yes, ma'am. Many type of lasers are available for different clinical applications, such as CO2, argon, ND-YAG, ATP, and diode lasers. Among them, CO2 carbon dioxide laser is preferred for laryngeal lesion, as it allows precise cutting and shallow penetration of the tissue with the bloodless surgical feed because of its excellent hemostatic property.
Okay. Now, what precautions will you take during the laser surgery?
Laser surgery comes with significant health hazards. Appropriate safety measures should be adopted for prevention of such hazards. Laser causes irreversible damage to the cornea and retina. Saline-soaked eye pad and eyeglasses should be used for patient, and OT personnel should wear wavelength-specific laser protective glasses. It can cause burns of the exposed skin and surgical drape, and prevented by the wet surgical drape and towel. Using smoke evacuator at the surgical site and wearing appropriate mask, we can prevent the harmful effect of laser flame. Airway laser hazards occur when it strikes the unprotected ET tube surface and producing a hole in it and exposing the fuel in oxygen-rich gases through the tube and causes blowtorch like fire.
Yes, so airway fire is a risk, there is definitely a risk of airway fire when you are using the laser. So how will you manage if there is airway fire?
If there is any laser air fire, so I manage this patient with the cessation of the ventilation and turn off all anesthetic gases, including oxygen, extinguish the fire with saline solution, remove the ET tube after deflating the cuff, and ensure the whole the ET tube should be removed. Examine the airway for burn and the foreign body such as packing material and ET tube fragment. After securing the examining the airway, I will ventilate the child with bag mask ventilation.
Yes, thank you, Dr. Kaushik.
Thank you, madam.
Now, ma'am, please.
Ma'am, we have a few questions in the chat box. Would you like
Yes,
to take them?
yeah,
So
ma'am,
we
sure,
have
ma'am.
the first question is, do we have MLS tube for pediatric patients?
Yes, ma'am. Actually, the size of the MLS tube ranges from 3 to 5. That is, 4 to 6. That is a 4 millimeter internal diameter, 5 millimeter, and the 6 millimeter. So if the child is very young, that is a 1 or 2 years old, it's very difficult to use, but it's not very difficult. Rather, it's almost impossible to use a MLS tube of 4 millimeter internal diameter. And rather, in the MLS tube, the outer diameter is slightly more in compared to the outer diameter of the standard endotracheal tube. So if it is possible to introduce a 4 millimeter internal diameter MLS in a child, then you can use it, no problem. There is no contraindication, obviously, rather it is preferable. But the problem of MLS in the pediatric patient lies with the size. It is not, it's difficult to get the proper size. There, usually it is either done with the normal endotracheal tube, that is a carved variety, or it can be done with the armored tube. As it has an added advantage that it prevents the kinking. We can easily introduce the carved armored tube. It will prevent aspiration, and we can also maintain the ventilation, and at the same time it prevents the kinking.
Next question is, what are the advantages of MLS tube, and can an endotracheal tube with a smaller diameter be used instead of an MLS tube?
Yeah, sure. Rather, we have to be ready with the endotracheal tube with smaller diameter. If we calculate the tube size, normally what we do in the pediatric patient, we calculate the tube size depending on the age of the patient. But here we have to definitely keep a smaller size tube. And here I have already mentioned that your history and physical examination will give you a rough idea about the severity of airway obstruction. And moreover, the indirect laryngoscopy, which is done by the ENT surgeon, will tell you actually if you can see actually what is the condition of the vocal cord, and from seeing the condition of the vocal cord you can have a rough idea of the tube size. So if you think that the 4 millimeter internal diameter MLS can be introduced, then you can try with this tube, no problem. But if you fail to introduce, you cannot just poke like a foreign body. So you have to use a smaller size endotracheal tube. And again, preferable is the armored tube, that is a carved armored tube. And if you don't have it, then the last option is obviously the standard endotracheal tube, but obviously the carved variety is preferable.
So, ma'am, for the benefit of our postgraduate students, could you please explain again the role of tracheostomy in the papilloma surgeries?
Yeah, it is actually said that, but actually what we think, there is an obstruction at the level of the vocal cord. So it's a normal tendency that we do a preoperative tracheostomy. Our task will be very easy. There is no question of sharing the airway, no question of any losing the airway. We are completely secured. But it is said that when we are doing the tracheostomy, there is a raw area. Actually, this is actually the laryngeal papilloma is caused by the human papilloma virus type 6 and type 11. And when there is a raw area, there is seeding of these viruses. So if you do a tracheostomy, the tracheostomy stoma, initially the most commonest site of this location of the papilloma is the vocal cord, it's the larynx. They are mainly restricted to within the larynx. But if you have done a tracheostomy, then there will be seeding of the viruses at the tracheostomy stoma. So you are actually facilitating the spread of the virus. And you can't do it. Obviously, that is why the tracheostomy is usually not indicated. Rather, we try to avoid as much as possible not to the tracheostomy. And moreover, in a child, the tracheostomy, if you perform the tracheostomy, the decannulation is again a problem, because there is always chance of so many complications and the child becomes completely dependent on the tracheostomy. So whenever you try to decannulate the child, it becomes almost impossible. And this patient, there is always chance of recurrence. They are mostly posted for the repeated surgeries. So it has been seen that we have put a tracheostomy tube and the child is coming again and again with that tracheostomy stoma for the repeated surgery. It will make our task easier, but it's not good for the patient. So we should try to restrict the tracheostomy as far as possible. But obviously, if there is no other way, then we have to do it.
Right. So what is the role of awake intubation for a bigger polyp?
Awake intubation in a pediatric
Bigger
patient.
polyp.
Okay.
In a pediatric patient.
Okay. Awake intubation means there is actually two, but awake means baby is fully awake. It is, I think it is almost impossible, because a 4 years old child or even a 5 or 6 years old child will not cooperate. But one option is that if the child is a relatively around the age of 5 or 6 years, if he cooperates, then we can go for awake intubation. That is okay. But if the child doesn't cooperate so much, here we have to maintain the spontaneous respiration, as I have already mentioned, by oxygen and sevoflurane, and then we can intubate the child. And if you think that it might be difficult, then another option is you can use a fiber optic bronchoscope. If you feel that you are more confident with the fiber optic bronchoscope, you can use that. And there is endoscopic mask is available. So the endoscopic mask has the advantage is that there are actually two ports. Through one port, you can attach the pediatric breathing circuit and you can maintain the anesthesia by oxygen sevoflurane. So it will keep the child sedated. And with the other port, you can introduce a pediatric fiber optic bronchoscope and then you intubate.
Dr. Sudeshna,
Yes, sir.
I have one point here.
Yes, sir. Sure, sir.
Regarding this awake, either awake intubation or awake fiber optic intubation to a child, whether from 1 year to 10 years, suppose it's our own child, we are putting it on the table. The site of the operation theater, the person surrounding that patient, then all type of conversation happening, the noise of the instruments, so many things are there.
Exactly.
It is going to cause shivers in the spine of a pediatric patient, which can be best understood by a pediatric psychologist.
Exactly, sir. Exactly.
Whatever we are doing for the safety of patient, no doubt about that. We are doing for the airway protection. That is our prime importance in such patients, the airway protection. But while doing so, what we are doing, this procedure, suppose it's a very simple procedure. The foreign body will be taken out, whatever the things, other things will be taken out, papillomatosis will be removed. So many things will be removed in any airway. So many procedures can be performed in such patients. But at the end of the day, that child will have such a post-procedural psychosis that will be playing a very heavy role on his life, his part. I have gone through that. I've gone through that, not through the procedure, but as a child, when somebody introduced me to some, the things which were very frightening, that didn't go till you attain an age of a teen, 13 to 14 years, when you start understanding the world around you. These type of studies, the procedures are not documented in the literature to that extent. So in our Indian culture, we don't care about these type of things. We are more concerned about the procedural gains, about the safety of the procedures, but not about the psychological or whatever you call the socio-physiological well-being of the patient. So how to tackle these situations in that, how the anesthesiologists can advance themselves to come over these things, because this is an advancing science. Here you can educate, here you can train, here you can modify the techniques so that we don't lead, because surgical part is not a difficult in these cases, because when you are anesthesia, it's the only pre-anesthesia procedures that is more traumatic for such patients, and a little maybe a little post-anesthesia traumatic situation. So this is very important. So how to deal with such situation?
So this is a very relevant question. Actually, I even don't know what should I say. Rather, but I think the pre-anesthetic checkup here plays a very important role. And if it is possible, because most of the patients come repeatedly for the same surgery, so if we can build a rapport in the first visit, then the same anesthesiologist, if possible, I'm not sure whether
Yes.
it is possible or not. If the
Agreed.
same anesthesiologist continue the surgery, to provide the anesthesia and especially the pre-anesthetic checkup every time, then it will definitely help the child. We have to actually build a rapport. This is the main thing.
But a foreign body doesn't give you much time to build a rapport. So
No, I'm not talking about the foreign body. I'm mainly talking about the
papilloma. Basically, no, I'm talking on the both fronts now.
Okay,
I'm taking about both cases in between.
If it is a foreign body, then obviously we are more concerned about the patient's safety. That is the physical safety. The oxygen saturation, ventilation, and everything comes in our mind much faster than the psychological aspect. But definitely we should take care of that.
What about the the pre-procedural sedations, which at least conscious sedation is out of our preview now. It's obsolete. There is no terminology like conscious sedation now. We sedate to a patient to such an extent that the patient obeys the commands of the attending anesthesiologist and attending physicians or a surgeon. I think that has to be modified, incorporated into our literature, into our textbooks, into our practices, where the child attains such a state that the child obeys whatever is told to the child from the pre-operative area to the operative area, or to the pre-procedural to the procedural area. And I think that's how our science can modify itself, where we can take the patient to such in the lovely arms, good arms, and the best person is a female doctor or a female nurse who knows how to rear these kids in their arms. I think that's a way to go in the socio-behavioral modifications of anesthesiology. These are the things I think we should develop on, rather than just putting any technician, male technician who doesn't know, he just carry the child, sometime even with a force, something like that. There are so many limitations in our procedure of transportation from pre-procedural to the procedural room, or from the pre-OT to the OT room. I think there are certain limitations. We can improve upon that. That's what I want to say as a whole from this type of things. And I think you have done a wonderful job in doing everything. Your answers are always good. And I want Madhuri also to say certain things. She has come out with a good face to give suggestions. Dr. Madhuri, please.
Yeah, with excellent discussion. I think we have really exploited the pediatric airway today. I would just like to add two things, that bronchoscopy and this surgery for papillomatosis, these are accompanied by a huge stress response because you're manipulating the airway. So we have to take some measures to reduce the stress response also. And secondly, the problem of awareness. These procedures are often accompanied by intraoperative awareness. So we have to tackle this also, right? And the role of dexmedetomidine as pre-medication in these procedures, could we use them? Could we use that?
Yeah, that's a good area. Good area, I think. We can explore that in the research academics also.
Yes.
Even the practitioners can do that. You know that it's so safe in the pediatric age group also. It's a very safe drug now. It has been established, dexmedetomidine sedation for the pre-procedural time, that it can really help you in inducing this child to getting the operative procedure done. I think dexmedetomidine is a wonder drug. Long back it has been labeled that, and I think that's a way to go forward from that.
And one more role is of the preoperative nasal laryngoscopy, endoscopic scopy, to visualize under local, to visualize the upper airway. That is also one thing which is often done. So before you give general anesthesia, the scope is passed through the nose under local spray, and then you can visualize whatever pathology is there, upper airway, so that you can get an idea of how you're going to manage. So that is one more field, like one more option.
But
Ma'am, there's sorry, sir.
Doctor,
Sorry.
Parul, just wait. I just
Just-
want to congratulate Sudeshna, Swapandeep, and Yogi ma'am, because they have been answering those questions which have got a relevance in the clinical practice, in the theory practice, in the PG examination. The way they are answering these things, the way they are tackling these things is very important, and that's the beauty of this class. They were a little nervous in the beginning of the class. Now they're so confident of answering anything. And I think that's the way to go about it. The PGs are good. PGs are not making any blunder. This is what a PG interactive class means. That means you have to come out with solutions for the PGs, for the academicians, for the practitioners. And Dr. Madhuri, Dr. Parul, Dr. Nishant, all are good, I think, in handling these situations. Now, Parul, please, you proceed.
Sir, there is another question which says, ma'am, do you have any experience about endotracheal tube, which is a laser resistant tube? Have you used anything like that? Because in literature, there are laser resistant tubes available. So what is your experience about it?
Is this question to Madhuri ma'am or me?
No, towards you, ma'am.
Anybody who has an experience can
Let
answer.
Sudeshna answer. Let Sudeshna answer.
So frankly speaking, I have used laser in the adult patients, and I have done the laryngeal papilloma excision in the pediatric patient not using the laser. This is a clear confession. But as in the literature, I have found that laser tubes are also available for the pediatric patients. But again, the problem lies with the size of the tube. Because when we are using the laser tube, there is a Mallinckrodt laser flex tube. These are all stainless tube. There are two cups, and the outer, they're quite outer diameter is much bigger. So it is always difficult to negotiate the tube. And also there is a chance of airway trauma, as it is a stainless steel tube. So there is more chance of trauma. The resistance is also high. The internal diameter is relatively less in these tubes. And as we know, in the pediatric patient, the airway resistance is already high. So if we are trying to intubate the child and ventilate the child through a narrow tube, the airway resistance will obviously be higher. So these are
to the power of 4. Just to the power of 4.
Exactly, sir. To the power of 4. Exactly. But definitely, sir or ma'am, if you have any practical experience, please share with us. I don't have the practical experience.
No, I like the concept when the moderators and chairpersons, they share everything in a very good manner. Our branch is a specialty branch which always shares honesty, whatever we have up to, because the theoretical thing, the bookish thing don't teach us everything. It's our experience where we lead to the new, reforms, new innovations, new methodologies, which they later on come to the journal, then publish in the books also. That's why our branch is such a dynamic branch, which is leading the way, which branch has a date of its inception. And since then, it has come a long way, because today we are advancing to these levels, and the PG classes has progressed to another level where we always dwell upon the things which has advancements. And the teachers, during these interactions, we get so many experiences, especially on the practitioners. I always love their inputs because they encounter so many cases single-handedly, without much support and without much resources and without much human, manpower. So whatever their experiences are, those are imbibed in these classes also. And I think whatever the solutions we get from the discussions, these will be imbibed tomorrow into the textbooks of anesthesiology, whether it's a national or international. And we will be coming out with many national projects also, where such classes will definitely have a role to project these innovations, these techniques, these methodologies into those books. I think it's a good. Today, I'm really feeling very proud that everything is answered in such a meticulous manner. And Dr. Maushmi was very much, little bit, not much, I think little bit apprehensive that what is going to happen with these classes. But I think the PGs were very good. Dr. Sudeshna, Dr. Sapandi, and Madam herself, they answered everything very well. And Parul, any more questions here?
So there's one more question. The question is, can regular tube with cuff inflated with normal saline be used for a laser surgery?
No, this is obviously a big no, because there are also certain case reports which have been published, and it shows that there was airway fire when they have used the normal endotracheal tube. So there are actually a few options. If you're doing laser surgery in a pediatric patient, the first option is obviously you are to use the laser tube. This is number one. But if you don't have it, then what are your options? One option is that you go for the tubeless techniques. That is, you can go with the spontaneous respiration, the intermittent apnea technique, or the jet ventilation. These are a different aspect. And the third option is, this is very rarely used, that is, you can use the normal endotracheal tube, but it has to be covered with the copper or the aluminum foil. But again, here the same problem lies, because whenever you are covering the tube with the aluminum foil, the outer diameter gets increased. So you have to again use a very smaller diameter of the tube, the internal diameter tube. In the same problem, the airway resistance will be increased. So obviously the first choice is laser tube. If it's not available, then it's better to go with the tubeless techniques.
Thank you, ma'am. We have Dr. Surekha Chauhan, ma'am. Ma'am, would you like to add to something?
Just for information, I'll share one interesting case. She was a 35-year lady operated for tonsillectomy in private, and just 2-3 months back, it was a history. And that was a era about 25 years back, and then that time we were using red rubber endotracheal tube. And then it was diagnosed the she came as a strider to the ENT department, and then it was diagnosed to have a papilloma developed secondary to the red rubber endotracheal tube. That case was managed by the surgeon. We had used a Portex tube for her that time. That much only I wanted to share.
Thank you, ma'am. I think these are very valuable suggestions.
Yeah, very rare, but we did not publish. But actually, we should have
No,
published
ma'am.
that.
See, ma'am. See, the science has advanced. We cannot go back to the methods which were used previously to get published to mislead the thing.
No, it's not. But this was
Because
an incident.
red rubber tube, ma'am, we have seen now in the museum. Now we just see for the viva only during the PG examinations.
Yeah.
I don't think so. They will ever get a chance to get published.
Yeah,
but
yeah.
definitely they will get a chance to publish in
Whatever,
the history.
whatever mentioned in the book really happens. That I wanted to
Yeah,
make
it really, ma'am.
alert about.
We are so nice.
Thank you.
So thankful to you being a part of these discussions always and giving your important tips. Dr. Madhuri, you want to ask something?
Yeah, I just wanted to add, there was one question on the laser tube, na? So in between, we had a supply of laser resistant tubes in our hospital. And I remember the cuff was such that we had to inflate it with methylene blue. So the logic is that if the cuff gets damaged by the laser, then this methylene blue serves as an indicator. So I just remembered that question was there, no? Have you used laser resistant tracheal tubes? We have, and they're single use tubes.
Good. Dr. Madhuri always come with a good, explanation.
No, I just remembered we had a supply.
After
that, we didn't get it again.
Encourage these things.
After that,
Parul, I think the questions have been finished.
Yes, sir. There are no more questions, and the house is open. Would somebody like to add something?
Yeah, anybody wants to give the suggestion we have got? Let me see how many
share their
minutes.
experience.
4 to 5 minutes.
Hello.
Yeah, Dr. Mohan, sir.
Yes.
Hi, sir. I cannot resist myself with that. In PG days, we used to use rigid bronchoscope to remove foreign body with rigid bronchoscope. That time, not nowadays. It was easier to get out as compared to the fiber optic bronchoscope, because the forceps are very small in fiber optic bronchoscope. And secondly, madam correctly said, we used to cover those endotracheal tube with the aluminum foil also to while we use lasers.
Even I used to do that always.
Yeah. Yes, sir. Yes, sir. But nowadays the main advancement is there. That time we used to attach that JR circuit to the bronchoscope and ventilate the patient.
That can be done with a special
somehow,
connector.
Yeah. Ventilating special connector was there, so we could ventilate. And sometimes we push the foreign body to one side and then ventilate and again re-intubate, because that time pulse ox was also not there.
Sir,
Oximetry
even
was
those
also not
techniques
available.
are still viable today, even if depending on the.
If you don't have any facility, you have to do it. And these are the
I think in the
emergencies.
practice, if you in the nursing home, if you are viable, if you are good, competent
Yes.
enough, you can choose those
To
techniques.
get a bronchoscope is very difficult in some places.
Bronchoscopes are not
Nowadays
available
also,
everywhere, sir. I am telling you, sir, there
and
are
expertise
almost
is
now,
needed to use the bronchoscope.
sir, there are almost 600
Expertise
medical
is
colleges. It is not available
Yes.
maybe in the 300 medical colleges.
Yes, sir.
This is a
Yes,
fact.
sir. And you need expertise to use bronchoscope also.
Yeah. Sir, even after having expertise of 20,
Because one
3
drop
years,
of the blood in the
23 years, sir, I'm
bronchoscope, you
still
can't
say
see.
in a foreign body, it's a very difficult to use.
Yes. Because little bit blood, you can't see anything inside.
Yeah, anything, definitely.
Yeah. Thank you, sir. Thanks a lot.
Thank you, sir. Anybody else want to suggest or give inputs? They can unmute themselves and they can say here. Actually, we always encourage people to come forward. Don't feel embarrassed, because whatever being discussed on this platform, it is not going to be given in the examinations or anywhere. It is going to be discussed here for the benefit of the patients and for our PG students. You can always come with your suggestions. Madam has raised hand again.
Yeah, that I just wanted to say that it is not only, it is mainly the coordination between the ENT surgeon, the anesthesiologist, which is very, very important for success, and a good knowledge of the instruments which are being used. Like if you're using the bronchoscope, we should know all the parts of the bronchoscope. We should have the correct outlet connections ready, the correct size ones. And if you're using a ventilation instrument, you should know perfectly well how to use it. This is very important for good safe and good perioperative outcomes.
And I will
This
add
is
it
for the-
further.
Yeah.
I will add it to further.
Yeah.
Apart from these things, what you add more is your attitude. You should have attitude of sacrificing it there where you think you cannot do it. No ego. You should not work for your glory that I can do it. Or surgeon cannot do it, I will do it. The surgeon is good, let the surgeon do it. No go for glory. And also the safety of the patient is a priority. At that time, you withdraw yourself. See, there are anesthesiologists, the most intelligent person in the operation theater in these type of cases. They should know the limitations. They should know the limit where they can work, where they can go, to what extent they can try to retrieve that foreign body. If they cannot, the right time is to withdraw yourself. Tell the surgeons. I think the more important, I will also like to have a pulmonary physician also there. They're very well experienced in these type of cases. They're being doing the bronchoscopies in the TB cases and other cases. I will like to have suppose a difficult foreign body case. I will like to have a pulmonary physician there. So the teamwork always is a very suitable for removing such bodies. The surgeon, the anesthesiologist, and the pulmonary, they are watching each other. And that is the best for a patient. You cannot go alone. You cannot go in your own way, because our own way may be sometimes detrimental to the patient. Rather, the three people sitting together deciding about that particular situation is more important to save the life of a patient.
Yes.
That's the best way to do it. And these things are not written textbooks, I'm telling you. These have to be practiced, whether in the practice in the periphery, or in the institution, or in the corporate hospital. These are applicable everywhere.
Agreed.
I think people have to give suggestions to these things also.
Yes.
So do we have any more comments?
I think it's a wonderful class. Dr. Mosby ma'am, she is one of the, pioneer and one of the, leading light for this class. And I'm thankful to Dr. Madhuri. She contacted Madam Mosami for this class. And because I was busy in the election matter of the ISA, so it was being done on the behalf of me only on the national headquarters. Dr. Madhuri coordinated with her. Everything went fine, and the class was very good. And Dr. Salona, Dr. Kaushik, they answered everything beautifully without doing any blunders. And that's what I think that HOD always stands for. They teach their PG students in such a fine manner. I think we should be felicitating them with their certificates also. That's a tradition. Just tell me when my screen is being seen by everyone.
Yes, sir. Your screen is visible, sir.
Mosmi ma'am, as a part of felicitation from the ISA National Headquarters, myself, Dr. Madhuri, Dr. Parul, Dr. Nishant, we want to felicitate you with our certificates for this class. My president, myself, and our academic chairman.
Thank you so much, sir.
Thank you, ma'am, for making this class a huge success. Dr. Sudeshna, you did a wonderful job in answering so many volleys, so many critical questions. And I really appreciate your knowledge about this pediatric airway, the complications. You did a wonderful job, ma'am.
Thank you, sir. Thank you so much, sir.
Dr. Swapan,
Yes, sir.
you have been the right hand of ma'am, I think. To the left side, but. So, thank you.
Yes, sir, you are absolutely right.
He's the right hand, but it's in the left side.
Yes.
That's what I made of.
Right, left, and shoulder of me.
So, thank you, Dr. Swapan. It was a beautiful class.
Thank you, sir. Thank you so much.
Yeah. Dr. Salona, really, you were very confident. The way you smiled, the way you answered, the way you handled all the volleys. It was a good part, and we are proud of you. And I think this was your pre-final. You have passed it, and you will be passing in the final examination also. And Dr. Kaushik, you were more mature than your age. The way you answered everything. So I think you have already passed your pre-final examination. The final will be given, number will be given by Madam Mosmi only. Even the externals come for your examination. And lastly, Dr. Parul.
Thank you, sir.
How many certificates you need? Tell me.
Sir, jitne mile
You
kam
always
hai.
get a certificate for comparing and these things. No certificates for me or Dr. Madhuri or Dr. Nisha.
Sir, aapko nahi hame zarurat hai.
No. Anyway, it was a beautiful class today, well conducted, because this topic was very hot topic. Short cases, they do come, and the PG sometimes they get entrapped in answering the questions. I think if I go by Dr. Madhuri's version, if the people, the third year PG students, they watch this class, they will be able to answer everything. Whatever Dr. Mosmi's department has done today, they have given all the questions which can be answered by everyone. Beautiful class, and very well conducted by Dr. Parul, and very well supported by Dr. Madhuri and Dr. Nishant and me also. I can add my name here at the last. So it's a very well conducted class, and we can, I think we're proud of it. Ma'am, we will be associated with you. I will be calling you personally for the research works also on these type of topics. So we will be associated again with you for this thing, ma'am.
Thank you, sir.
Thank you,
sir.
Thank you, Ajba, for the part of this academic event. And I thank all the seniors, all the ISA members, the PG students who attended this class, especially my practitioners. I always love practitioners. They should be the part of this class. They love these things because, these things discussed here are not discussed anywhere in any conference or CMEs. They are discussed only here. And thank you everyone. And we always end the class by saying,
Long live ISA.
Long live ISA. Jai Hind.
Jai.
Thank you.
Jai Hind.
Thank you, sir. Good night, everyone.